the microphone here so folks online can hear. Our first speaker is Laura Norton-Cruz. She's the director of the Alaska Resilience Initiative, which is a program of the Alaska Children's Trust. And she's going to speak about the Alaska Resilience Initiative. I'll get you some slides here. And you should have a clicker up there.
And can folks online hear?
There you go.
All right, can folks online hear okay?
I think it's fine, thanks.
So thank you so much for this opportunity. It really is an honor. As Cheryl said, I'm the director of the Alaska Resilience Initiative. We're a cross-sector statewide network with a common agenda. So all players from all sectors share this common agenda of mobilizing Alaska to end child maltreatment, intergenerational and systemic trauma through healing and strategic advocacy. What I'm going to briefly go over in this amount of time we have today is what our approach is, how we approach this work, what our scope is, and what it is that we do. So this formed because we knew I had been traveling around Alaska. I had been working in the tribal health system. I've been traveling around Alaska and seeing that all over the state, there were people from diverse parts of the state in different sectors thinking about the science of ACEs, the neurosciences, trauma, resilience, and doing work on it. But there wasn't one network connecting all these people. At the same time, the local foundations, Alaska Children's Trust, Alaska Mental Health Trust Authority, Rasmus Foundation, and the Alaska Children's Trust were thinking the same thing and strategizing about what they as funders could do to bring people together. And so they wrote a grant to the Health Federation of Philadelphia for us to become one of 14 pilot communities around the country to do cross-sector network building around trauma and resilience. And that's how I was able to be hired and grow this initiative. Using a collective impact approach, because there were all these wonderful, thoughtful, innovative things happening around the state. So we didn't need to direct it. We needed to let this collective sort of bring their wisdom together and direct what needed to happen. So that's the approach that we took. So the picture thing is happening. We started first by gathering together, and the picture's not showing up, I'm afraid, those who, Alaska Native and Native American people around the state who are doing trauma and resilience work, to have them guide how we frame the issue, how we approach and talk about the issue. And that was the first to really set the tone in the direction for the entire initiative. After that, we gathered together everyone we could think of, every department, tribe, school, organization who is doing trauma and resilience work in Alaska as a kickoff to figure out how to run a collective impact initiative that people wanted to participate in. That wasn't just yet another coalition to attend meetings of, but that would support everyone's work and leverage our power together. And so collectively, as the people gathered there, we came up with a structure for the initiative, which ended up having a steering committee, which represented every region and sector of the state, and 3 work groups. So that's how we approach the work very collectively. What informs us, that is what we consider under our purview of resilience, is we're informed by the neurosciences. So this guides everything we do, the neurobiology, epigenetics, adverse childhood experiences, and resilience sciences. But we also understand that this is ancestral knowledge. That many Indigenous peoples from throughout the globe have known how to take care of, how to assure healthy, safe pregnancies and infancies and childhoods in order to support healthy adult populations in the next generation. And so we draw on both the neurosciences and ancestral knowledge about trauma and resilience, and really look to local Alaska Native approaches to understanding trauma and resilience to be part of how we teach and how we guide the work. With the goal of preventing trauma in the first place and helping people heal, survive, and thrive after trauma. So the way that we view this work is very much within the social, the ecological model, right? That people exist within all of these systems and that we need to have interventions that approach trauma and resilience at all these different system levels. What do we mean when we talk about trauma and resilience? This is one of the things that sets us apart, I think, from some of the other states that do this work, is that we talk about ACEs, right? Trauma that occurs within families, adverse childhood experiences, but we also conceive of it as including cultural and collective forms of trauma. which includes, of course, historical trauma from colonization and its ongoing effects, as well as other forms of collective trauma, such as war, political violence and repression, community violence, inequities, increases in trauma based on social identities, such as being lesbian, gay, bisexual, transgender, or queer, being at higher risk of being punished in school based on race, and of course that potentially exacerbating the effects of trauma. If you go to school and you're experiencing trauma at home and then you act out at school, if you're more likely to be suspended because you're Black or because you're Alaska Native, or because you're Pacific Islander, that can increase the effects of trauma. And so we conceive of trauma in this larger societal framework and how that leads to stigma and criminalization. We also look at inequities such as access to high quality childcare based on income, right? And we know that that's really crucial for brain development in the early years, as well as housing inequities, et cetera. So thinking of trauma in this socio-ecological framework. Oh, darn, so the photos aren't showing up as well. So that means that in terms of interventions for resilience building, we're looking at how to build up individual capabilities and beliefs in children and adults. Oh.
They're showing up on the online version.
Not the same without the pictures. I apologize.
Sorry.
How to promote attachment and belonging on an individual and family and systems level. How can hospitals better promote attachment and belonging? How can school systems approach attachment and belonging? How do we alter and support institutions and systems to change and be more trauma informed? Right, across different kinds of systems, there are certain principles. And the way we conceive of this is trauma-informed and culturally responsive systems. And then how do we support local communities and cultures? And luckily, we are a statewide initiative, but there are a number of regional coalitions that are doing this work locally, and we have a relationship connecting those regions to each other, creating healthy communities. And then what kinds of levers of policy can we effect that will create the most positive effect for all of us? What we believe in, there are certain principles that guide our work. And we gathered this last May to put those down on paper and really understand what those are into a white paper. And I have copies of this if any of you are interested in. And this white paper really explores what our foundational premises are, what it is that we believe in and are working towards, and what are our ethics for how we show up to this work. And we think this really matters for this work making a difference, and this work making a difference for all Alaskans, that we show up to this work with ethics every day, and that we center equity at the core of our work. And this was created by the entire steering committee, but really the leadership of our two co-chairs is fundamental in having this equity focus. And this is something that we hope to offer to other resilience coalitions around the country, the importance of having leadership and voice of Alaska Native people, of Indigenous people, of people of color guiding this work and keeping equity at the center of it. And I don't have much time to go into what kind of all the areas of our work, but our main functions are creating a network that connects people doing trauma and resilience work across the state, to increase communication and collaboration and sharing of resources and tools, to support communications efforts, which means right now we're building a curriculum for training of trainers to have a cohort of trainers who can go out into any professional setting and teach people. And we'll have different versions for healthcare providers, policymakers, early childhood educators and parents, educators, et cetera. And then systems change work. So we're doing some direct work with schools, with the Anchorage School District, for example, and then trying to network together the people doing system change work in schools across the state. And then also elevate examples of really positive systems change work. And then lastly, policy. So we're figuring out our policy priorities, which Medicaid reimbursement issues, with a small tweak could make a big difference in people's well-being, that type of thing. So I asked in advance of this presentation, I asked my steering committee members, if you had the chance to ask the U.S. Arctic Research Commission to consider certain research questions that are in line with their agenda, what would those be? And there are about 3 questions that we came up with as steering committee. One is about I guess I'll back up. We believe that it's vital to address social injustices and oppression and systemic traumas as we address early childhood intrafamilial forms of trauma, the issue of complex trauma in child development and how that affects lifelong health. We think it's really important to address that while looking at the systems that families are a part of, while looking at the way that children and their families interact with school and public assistance and government policies and so on, and economics. And in order to make the case for why this is important, because there's a lot of pushback about this. When you go into a school system and you say, we need to talk about trauma and also racism, there is a lot of pushback. And so I think it would be really powerful to have data showing why this is so important. And there's not very much data even nationally published on this. And so one of the most basic research questions that I would like to see addressed is, do the effects of adverse childhood experiences differ by the social determinants of health? Right, so we know that an increase in ACEs has this dose-response relationship with poor health outcomes, but is that relationship differ, based on different social determinants of health, based on race, based on socioeconomic status, based on sexual orientation, et cetera? There's very little research on this. And I think that would be an important question. And then if it does, what are the mediating factors? So what is it? Is it lack of access to care? Is it additional forms of toxic stress that these children are experiencing? Is it that stigma, right? Is it criminalization? What are the factors that are creating this differential effect of ACEs? Another question would be about looking at, there are many villages in Alaska that are doing really well, that are thriving in comparison to other villages. So children, there are fewer admissions for RSV, for example. There are fewer incidences of domestic violence, more social cohesion, et cetera. Now, how you measure this is another question, and that would be something to explore, all the different measurements of what it means to be doing well. But there are communities that are doing considerably well, and then there are communities that are struggling a lot more. And what are the differences in this? And specifically, so for example, a community like Kwingillingok, where the elders got together and created a child protection team, where they go in and use UBIC values and approaches to interact with families who might be struggling before abuse occurs in order to prevent it, right? So a community like Kwingillingok or a community like Unalakleet, what is it that has happened historically or is happening now in that place that supports that village to be doing better? And what are those factors, and can they be replicated in other communities, right? Are these things that can be learned and through mentorships and collaborations between villages can be supported in another village? So that's a question that I think is in line with ARI's, Alaska Resilience Initiative's interest in looking at Alaska Native-based resilience strategies and approaches, as well as in line with your recommendations and goal areas regarding local knowledge and Indigenous knowledge. Another research question that comes up a lot, I think, is this question of what leads to effective collaboration within and across communities, and what conditions support that. So what are the barriers? We want people to connect. We want people to not waste resources and reinvent the wheel. We want people to play well together so that they can maximize their effectiveness across sectors. But there are so many barriers to doing this. And this is my work every day as I'm trying to bring people together. And there are many, many barriers that I come across. And so I think it'd be helpful to understand what the barriers are and what leads to effective collaboration. We are trying to address this right now with an in-depth network survey and a series of interviews. So we'll share what we find out. But this is something I think we could use more research into. So lastly, I'm not sure we're running out of time, but we have a website. So if you want more information on the Alaska Resilience Initiative, we're easy to find online, akresilience.org. You can join our email list. We're on Facebook. We have a ACES Connection group as well. So thank you very much for your time.
Thank you, Laura. We're going to go on to the next presentation. And again, like the last session, we're going to have a discussion session at the end of the presentations. Our next speaker is Dr. Stacy Rasmus, and she comes to us from UAF and the Institute of Archaeobiology and CANHR. And she's going to speak about the Alaska Native Collaborative Hub for Resilience Research.
Great. Well, I want to thank you all again. Echo my the first presenter in expressing my honor for being here today. I really welcome the opportunity to share with you about an exciting new project, and I felt that Laura, you gave such a great, perfect. I think we might be able to answer one of those research questions. Yeah. So,
Give me the projector.
oh,
Just stand
Hold
by.
on
I
a
think
sec.
we're gonna
switch.
do a quick fix. I think.
Why don't you give me your computer? It's not going to reach you.
I'm gonna undo the speakers. Don't undo the other one. Let's see if that works. I think I may have to close the sides down though. I can do it. Maybe. No, just close this guy. Okay, and now go to make this as I can do this. Okay, don't think. Stay out of that. Okay.
okay, nice. Wow. Yeah, so lots of cool graphics are in store for you. All right, what I was asked to share with you today is about a new project. It's a new grant that was awarded to University of Alaska Fairbanks, although we have many partners throughout the state that I will be talking about, acknowledging. First off, I do want to acknowledge my collaborators in the Alaska Native Collaborative Hub for Research on Resilience. For short, I'll be referring to it as ANCHR, as again, we're hoping to anchor our state around this very important issue of the prevention of suicide and reduction of risk for suicide among Alaska Native youth. This was funded by a special initiative through the National Institute of Mental Health. NIH actually put some focused funding specifically into addressing the just chronic disparities and crises in American Indian and Alaska Native communities around particularly youth suicide. And so there were 3 collaborative hubs that were funded nationally, and Alaska received one of them. And we're very proud and very excited for this opportunity. And so Drs. Lisa Wexler and Chamberlain, my longtime collaborator, well, we've all worked together in the state and have conducted prior research that I'll just touch upon. And then the initiative will also be led by Vice Chancellor Yvonne Peter and Dr. Jessica Black at the UAF. The hub is meant to address, from a strengths-based and protective factors and resilience-focused way, the crisis that we have in Alaska around suicide with young people. This is a slide, again, just touching on the disparities. This is recent data from the Alaska Native Tribal Health Consortium Epidemiology Center, just came out in August. And within this report, it was acknowledged that, we haven't, at a statewide, when you look at the data statewide or or regionally, over the past 20 years, it looks like we haven't made too much gain. It's gone somewhat down, particularly in the last 3 to 4 or 5 years, but really not in a significant, tremendous way that we really hope to achieve. And but what it also shows is there are differences around the state, though, in prevalence of suicide. And typically, again, we see the highest rates in the rural areas, most heavily impacting upon Alaska Native young men, and again, so these vary within those populations. But something that's not typically looked at, and that was mentioned just in the presentation before mine, is that even within regions that are, we see the highest rates of suicide, there are communities that have very low prevalence or haven't experienced suicides, and in proximity to other communities, sometimes they're 10, 20 miles away, where other communities are experiencing epidemics or clusters of suicide. And so it makes the whole region look very disproportionately high, and you don't see the diversity, you don't see what the strengths are and the resilience in those communities, even within the same region. So I do prior research in the Yukon-Kuskokwim region, and the behavioral health director, Ray Daw, is presents often of the fact that of the 56 communities in the region, it's about 12% of the communities make up the disparity, so and contribute to that. So what the CANHR proposes to do, there's two primary aims for the hub. First is to create a research collaborative network in the state, which I will talk about in more detail in just a moment. And the second is to conduct a focused research study, the Alaska Native Community Resilience study, that will focus within the three regions of highest prevalence and rates for suicide historically, and to do a focused and systematic study looking at differences within region between communities with high and low protection and risk, looking at rates and but not just exclusively on suicide or suicide attempts, but also looking at all the social determinant factors that were outlined, looking at relative wellness and protection in relation to also looking at things like alcohol-related injury and other types of risk factors contributing to suicide. So the study is going to build on prior research from another part of the Arctic, in the Inuit Canadian Arctic, conducted by Chamberlain and Lalonde. And it was a real foundational study that has seen very little follow-up in terms of, they looked at Inuit communities, I think looked at about 40 communities, and were able to determine that a certain set of factors, communities expressing a certain set of 8 particular factors, things like tribal self-determination, again, access to resources, but there was a set of factors that correlated with high, and well, actually, if they were present, that was very correlated with lower prevalency of suicide, and if they were absent, so communities that had 3 or less factors had very high rates of suicide. So we plan on doing an Alaska extension of the study in Canada to see if we can prove it here. And then from that, though, this isn't just a discovery-based project. We plan on developing a tool then, if we're able to identify mechanisms that contribute to protection against suicide. We look to hopefully develop a tool for charting community resilience that communities can use to systematically target and build or advocate for resources to increase those protective systems and community level resources. The CANHR builds on prior research that I and my colleagues have done. This just don't expect you to read all that. Perhaps maybe you can have a printout of the slides, but I have been working with Dr. James Allen for almost 20 years in the YK Delta region with communities who've developed an approach to building strength and protection and resilience against suicide and alcohol misuse. And we have data showing very promising outcomes. Just 4 months ago, the Knazavic Toolbox Prevention was listed on the National Registry of Evidence-Based Programs and Practices. The link, I don't think I linked it on one of the slides. And then Dr. Lisa Wexler has been working in the Northwest Arctic and Bering Straits region for by a similar amount of time, and she also has focused on first exploratory research, looking at what's protective. And then she's developed intervention research to where they're promoting community conversations around suicide, looking at research and looking at local and community applications of research findings. So the specific aims of the CANHR, again, primarily our first aim is to spend this first year of the hub creating that collaborative network. We'd like to create a multi-layered tribal leadership structure that of course involves providers and all interested parties and advocates to get everyone at the table. So again, we hope to involve our decision makers, policy makers, those in seats that can really make a difference in terms of where funding is going around suicide prevention. We'd like to involve them in the Alaska Native Executive Advisory Committee that Vice Chancellor Yvonne Peter is organizing. We will have a research steering committee that will be made up of experts and stakeholder members from the 3 regions that are involved in the Alaska Native Community Resilience Study. So that will be the Yukon-Kuskokwim region, the Bering Straits, or Northwest Arctic. And then we'll have annual collaborative hub meetings that we hope will be, a flexible but as comprehensive as we can get it group of everyone, in Alaska that we hope to involve in sharing research, findings from our study, but also, sharing about what we're all doing. And it's just fascinating to hear about what the Children's Resilience Network is doing. So the Collaborative Hub is all these groups are currently being formed, and you all probably, if you haven't received an email from us and our team members already, you most likely will be. We're tentatively looking at April of 2018 for the Collaborative Hub meeting. So I guess that's something to put down. Our second aim is to strengthen the research infrastructure here in Alaska. We hope to build a really strong partnership with UAA, the Behavioral Health Sciences Center. Dr. Rhonda Johnson's a key partner. And so we're looking at, again, combining our resources and working throughout the UA system to address this issue together collaboratively. Additionally, so again, this goes back to the research study. So we aim to carry out the study in the 3 regions. And with the anchor and with the core support, we're hoping to be able to provide, again, the kinds of resources needed in Alaska, which has very unique challenges in terms of doing research, in terms of logistics and trying to keep us connected. It's very expensive for us to be flying everyone in to do these annual meetings. So again, we're putting a lot of focus and thought behind how we can create a network for sharing about this issue in a way that's also sustainable. So we have a 4th aim is our sustainability aim, where we are looking at dissemination and that translation from research to practice, and what we hope will be policy change too. Again, around looking at ways we're engaging communities in the development of strategies meant to increase those community and cultural strengths. How are they being involved? Because that's where essentially we're going to need to continue the services. So, we've got efforts to create tools from the research project, but also just building capacity for, within the Alaska Native tribal leadership structures for research. So, and again, and overall, we're hoping with the anchor to continue the strengths-based and resilience-focused and protective factors approaches so that, we're creating our young, healthy Alaska Native people, the next generation. So.
Great, thank you. And I'm not sure if Stacy's going to be able to stay for the discussion, but otherwise, if folks have questions and you're not here, I can get them to you.
That's great.
Okay, excellent. Our next speaker is Dr. Bert Boyer, who is the director of the Center for Alaska Native Health Research at the University of Alaska Fairbanks. He is going to speak to us about the American Indian Alaska Native Clinical and Translational Research Center.
Thanks. Thank you very much. I'm really honored to come back and speak to you, and I apologize for lack of a voice, but I'll try to stay close to the microphone so people online can hear me. So what I want to tell you about is a new program. It's a center grant. We initially had funding that really formed our Center for Alaska Native Health Research for 15 years through the NIH. A program called the IDEA program has a 15-year life cycle, and it ended in June. The NIH is really interested, though, in clinical translational research, and they define clinical research as research involving human participants. So we thought that there was an opportunity to write a proposal that would help facilitate capacity building in Alaska and Montana to address Alaska Native and American Indian health research priorities and health disparities. And the result of that was the formation of the American Indian Alaska Native Clinical Translational Research Program. We have, oh, there's a part.
Did you take it with you?
There we go. So we have several partners. The home institution, the administrative home, is Montana State University. And that was formerly led by Alan Harmson, who retired recently and is now led by a young woman named Jovanka Bojic. I'm a co-PI on the project at UAF, and then we have several other partners, two tribal organizations, AMTHC and South Central Foundation here in Anchorage, another tribal organization or community college, a tribal college at the Blackfeet Nation in Montana, and then we have a partnership with University of Montana and University of Alaska Anchorage. So unlike the first two talks that you heard that are very disease focused or discipline focused, priority focused, ours is very unfocused in the sense that people can apply to this program for pilot funding. And our goal is to provide the resources for them to become successful in receiving other extramurally funded grants. It's not, the people that can apply are not limited to the 7 institutions on this slide, but rather others throughout the state have applied and successfully, through our state and Montana, have applied and successfully received funding from this program. So I changed the slides with this. Oh, look at that. Well, that didn't come out as it looks on your screen. That's okay. I can work through it, and you don't need to see it anyway. This is just the organizational structure. So we have an administrative core that's co-led by myself and Jovanka Bojic. And then we have 4 other cores down here that you can't read, and hopefully they'll show up on the future slides, that are there to support investigators in gaining pilot data and working with American Indian Alaska Native communities to address their research priorities. So the first one, is the pilot project core. This is the one that most people are interested in because this is where 1/3 of the money in the entire $20 million program goes, and it's to support other people. That's led by Carrie Harris at University of Montana and Jocelyn Krebs, who's associated with University of Alaska Anchorage, but actually lives in Portland now. The goal of that is to basically give people money to support their development to be more competitive at getting future grants. Another picture of some of the people involved, Jocelyn and Carrie there. This is a slide that may be important for some people in the audience who want to know what sort of money are we awarding people. They're fairly sizable research grants from development grants. These are grants where you're not going to work with human participants yet, but you're trying to develop a partnership with a rural community or a tribe or some location that you don't have a lot of familiarity with, and you need introductions to, and you need to approach in a culturally respectful way. Pilot projects, or if you're a little bit further along, you get a lot more money, although we have reduced that to award more projects because people weren't spending out that money very quickly. That's more where you do have your IRB and you have a project and a community partnership already in place, maybe that came from the development grant in the first year. A lot of the first year development grants transition to second year pilot grants in the program. We tried sabbatical leave projects. Nobody applied, so we got rid of it. And then there are some other awards from diversity awards. People that are American Indian or Alaska Native and work in another investigator's lab can receive funding to do work in that lab, as well as travel awards, small grants, and community grants. Okay, so what about the cores? The first one that I'll talk about is the Community Engagement Core. It has 3 regional site directors. Scarlett Hopkins at UAF in our center, CANHR, is the director of the Community Engagement Core. And works with the Fairbanks region and rural regions in Alaska. Denise Dillard is the site director in Anchorage. She's the research director for the South Central Foundation. And Tony Ward is the research director for the entire state of Montana because it seemed to be a better model than having one site director in Missoula and one in Bozeman. We have research navigators that are also called community research associates. Mostly indigenous staff members who are at the various sites from South Central to Montana State, University of Montana, and Dan Uliassi works with us at University of Alaska Fairbanks. And these site directors are there to help investigators navigate how to do research with communities in a respectful way to prevent problems in the future. Two goals of this core are to develop a case study curriculum. People are always asking us, how do you work with Indigenous communities? And there's no paper or textbook or checklist that you can follow. So we wanted to work through case studies, examples, or stories, scenarios that we could explain how to engage rural and Indigenous communities. And then to support the investigators' development. And one other thing that I want to say about the Community Engagement Corps, they play a very critical role in the review process of the pilot projects. All of the Community Engagement Corps personnel get together and they review all of the pilot projects. And if any of the pilot projects are considered not appropriate or not culturally respectful, they can put not recommended for funding, and they're no longer considered by the rest of the CTR. So we take their input very seriously, and it's caused some problems with some investigators who have got that not recommended recommendation, and we're working through that, but we really, really want to support these investigators so that they do culturally appropriate work. We have a research design, epidemiology, and biostatistics core that's led by Tim Thomas. He's the research director at the ANTHC, and it's pretty straightforward what they do. They have a lot of people, most of them are biostatisticians and epidemiologists, to help people with study design issues. So here, here are the aims of that core: research design, epi, biostats, training and opportunities in that area, and also to develop some novel approaches, because sometimes in working with these communities, they're very small, there's power and sample size issues, so they're really trying to work with people to shore up their design and epidemiology part of the proposal. There's a professional development core led by Jane Shelby here at the University of Alaska Anchorage, and Doug Kaminsky at Montana State. And this core is all about mentoring. You can read the little bullets here if you want, but it's really trying to make sure that every investigator that successfully applies for funding, or that's applying for funding, gets the mentoring so that they don't make mistakes along the way, so that they're paired with a research-intensive investigator, so that they'll more likely have success when they submit their proposals for extramural funding. There's an evaluation core. As you might guess, they do summative and formative evaluation. They're very good evaluation core at Montana, led by Lisa Blank and Heather Almquist. And they're really sort of tracking how we engage, or our investigators engage with the various cores, and trying to find ways to build those networks and strengthen those investigator projects so that they're more successful. I thought you might just like to look through, I hope it's big enough for you to see, to look through the diversity of proposals. As I said at the very start, they're not focused on one particular health priority, but rather any priority of a American Indian or Alaska Native tribe in Alaska or Montana is acceptable for this sort of thing. So we had several pilot projects in year one, some of which have gone on to get a second year funding. I should point out a couple things. So the double asterisk means that the proposal was funded in a Native owned or managed organization, and we try as much as possible to fund Native investigators, and we've done that wherever we can. These are some of the developmental projects where people didn't really have a relationship with the community, and they started. So you can see everything from children's health to children's behavior to community-based problems in American Indian youth to trauma-focused projects. So you name it, it's open. If it's a priority of a community, we will seriously consider it for funding. Here are some of the pilot projects funded from year one. I think those were developmental projects, I apologize, on the very first slide. So here are some of the pilot projects. Again, the topics vary from nasopharyngeal cancer to this is physical activity and diet, to cardiac survival, to bacterial vaginosis and reproductive health in communities, to genetic variability of vitamin D. So you can see all over the map. And then last slide is what some of our pilot project 2-year funding went to. So you can see these 2 investigators continued on to a 2nd year of funding, and actually this one as well. And now first 5 investigators were all part of the 1st year of funding. And then some of the developmental projects have graduated into pilot projects. So I'll stop, and hopefully I finished on time, and let somebody else take over.
Great, thank you, Bert. We will have questions at the end, and just give us one moment. We're going to bring up the next presenter and presentation. Linda Chamberlain is next, and hold on one moment. I have to get my intro notes here so I get it right, because we had you. Linda is an adjunct at UAA, but your actual title is...
Well, yeah, I know that there's a complete lack of affiliations and organizations on my slide. I started the Alaska Family Violence Prevention Project in the 1990s, and I separated from government last May, moving my work outside state government. And fortunately, through the Fulbright Arctic Initiative, I've been in Finland a whole bunch, starting in 2015 and through 2016. And actually on my personal funding, I extended into 2017 because I learned so much. It really changed the work that I do. So that's sort of my, I guess I'm a free faller right now. There we go. So, oh great, graphic turned out. And what I wanted to say here is just, this is referred to in Alaska as an oil spill slide relative to health, looking at the connection between adverse childhood experiences, trauma, and health outcomes. This is cross-sectional state of Alaska data. And when we talk about trauma relative to mental health and well-being, it is not a theory, it is a fact. It is a fact that bears out with very, you can count on reliable statistics like population attributable fraction here, showing the connection between depression, substance abuse, not having health insurance. This is just one of those oil spill slides. And one of the interesting things where I put the star around low food security, because I had the opportunity to travel between the 8 Arctic states with Fulbright, is how often I would hear that this would be connected to the food scarcity issues relative to climate change, things that we have not traditionally considered as part of trauma in the interdisciplinary group of scientists that I was working with over that 2-year period, basically. It's about making the connections. And when we talk about trauma-informed care, these are key elements in terms of, from Stanslow, that generally whatever model you're going to look at for trauma-informed care approaches for mental health or otherwise, there's going to be agreement on the importance of recognizing the effects of trauma, that we want to create systems and such that we are not re-victimizing. Actually, when you drill down to look at trauma-informed care, it comes back to, I'm an affirmation of what we have already heard relative to talking about resilience. It really has its basis in the being resilience-informed. That's what makes a difference. The challenge, I think, is when we look at the gaps relative to trauma-informed care in the Arctic and other culturally diverse places, that we don't see models that are really incorporating the issues around collective and cultural trauma in the pure trauma-informed care model. So that is a big challenge. It's again where we all need to work together. One of the big ironies to me is that really the first building block of a trauma-informed care approach is addressing vicarious trauma, secondary trauma, how working with trauma in areas that are highly traumatized affects workers. In Alaska and elsewhere, we have a highly traumatized workforce, many traumatized organizations, and even to the level of traumatized communities. Until we really come up front and start dealing with the secondary or vicarious trauma, it's hard for our trauma-informed care approaches to be that effective. So it's a key building block in this. And then also when I find in conversations in communities when we talk about trauma-informed care, one of the first things that comes back is if we really involve communities and cultures in this conversation, that may not even be, they don't use the T word often. And even resilience, particularly across the Arctic, is a challenging term relative to talking about strengths, cultural values, and such. So getting some common language where we really have people's input and understanding of what we mean by these words and what we want to look like. And that is all very much a shift to a strengths-based approach and a strengths resiliency focus as opposed to a disease focus, which initially was the foundation of trauma-informed care. So I'm going to talk a bit about the lessons learned or insights that I had in Finland. The project was called Hard Times and Healing in the Arctic. My host country was Finland, and we started with I have looked at a lot of resilience research like my colleagues, but I never looked at it in an international Arctic perspective. So that's where I started with in this project, was doing an international review of the research on resilience in the Arctic, then looking at how the adverse childhood experience of data, that's domestic, looking at the connections between child abuse, domestic violence, substance abuse in the household, mental health issues in the household. We know that all of these things are good buddies and unfortunately cluster together, but I hadn't had the opportunity to look across the Arctic at what it looked like. And the project culminated in focus groups with the women and children shelters in Finland, which are very different than here because they started after World War II. People could easily get substance abuse treatment residentially for a year or more. The programs are set up that they serve both genders, which is very different than our approach in the US. So that was the qualitative part of the project. And I started in northern Finland, particularly talking to the Sami Educational Institute, and then working through, which does not have a mother and child shelter up north, and then working through other communities to down south. When in the resiliency review for the Arctic, these were the common factors. And I know we've already heard about these things and we know these things, but relative to trauma-informed care, how are these common Arctic resiliency factors, which are all about indigenous populations, because that's where the research is centered, how are they built into trauma-informed care models? That revitalization of language, cultural identity, supporting families and caregivers in a much more culturally traditional perspective that isn't just about the immediate family, but how family extends to being the community is a different perspective. And talking about this and really focusing on developing skills, that we are delivering skills to families and communities around healing, and that subsistence, that all these things are tied together. This is from the qualitative aspect of my project, and what I really want to lift out here, because it entirely changed my approach from 20 years of working in family violence, is whole family approach. It was very clear in Finland, and has been done for a long time, recognizing that when you work with one family member, on whether we're talking family violence, substance abuse, or other highly correlated issues like mental health and suicide risk, you are working with every member of the family. That is the very basis, along with a trauma framework to inform the work that they do, and very creative in terms of how that outreach immediately happens the minute one family member is accessing services for issues such as domestic violence, child abuse, neglect, and so forth. There is they use a system called MERIC, which it's an approach to assessment that allows interagency collaboration sharing of information, monthly meetings, but that's all set up ahead of time so you don't have those struggles down the line. So we know that we need more interagency collaboration to be trauma-informed, that it can't be mental health over here, it's substance abuse, suicide prevention, domestic violence, but it has to be planned in a way that really, from the assessment forward, and part of working with communities, that can happen. And of course, resources to be able for community, for universal education, to understand the implications. And these were the project outcomes so far, and kind of emerging strategies that they continue to work on with the partners that have developed. And I was connecting them to the goals in your report. We released an online open access, meaning anybody can get it. It's free, anyone can translate it, toolkit on basically trauma resiliency, thinking about trauma, what we mean by trauma-informed care, starting with the conversation around how do we talk about and address vicarious trauma. And that went live in the end of July on acesconnection.com through a group, an online community practice that we have called ACES, or Adverse Childhood Experiences in the Arctic. I am working with the University of Turku we are translating a resource that we have in Alaska. Actually, it's a national resource that helps families understand how trauma can affect their health, their parenting, their children, brain development, and so forth. Another aspect of the interdisciplinary research is that we have researchers from talk about we, it's kind of like the royal me, and my colleagues, but I have colleagues now I'm working with in Finland that will be coming over from the University of Lapland next year, and we will be collaborating particularly on research around family violence and looking at the kind of more insidious effects and opportunities for more collective response. I will say to you that in my work in Alaska and elsewhere, when I look at trauma-informed care, we tend to have this narrow thinking around particularly mental health settings and such, and the moving and shaking that I see happening in Alaska and across the country, but Alaska blows me away in this regard, is the trauma-sensitive school response. It is changing everything, in my mind, around early intervention, which I noticed as another aspect of your report and recommendations. And also, from that mental health perspective of having school-based programs like CBITS, a cognitive behavioral intervention for trauma, school-based program, and who our partners between mental health and schools can be. The final thing we'll say, and the organization I'm working with very closely now is Kipesitar International, which is an organization where we use a popular education approach to help communities, children, parents, kids can teach parents, parents can teach kids simple skills to promote resilience, healing, and self-regulation. We should have communities and circumstances where everyone knows simple tools, like the fact that just taking my finger to a pressure point beneath my nose is a critical acupressure point for panic attacks. How can we bring basic skills to communities for healing? So thank you for your time.
Thank you, Linda. All right, so I'm going to ask if the presenters in this panel could come up to the front. I'm going to see if there are any questions from the commission. I'm sorry?
I want to turn is this the one that?
Yeah. Oh, geez. Any questions from the, oh, Larry.
Thank you. Those are all really wonderful. Question for Linda. You talked about the commonality across the international spectrum. Were there also fundamental differences?
I take it if you're recording it, just come over here.
Thank you.
In the resilience research or the ACEs research, or both? Okay. Well, in the resilience research, it was amazing to me how much overlap there was. So I really didn't see differences that surprised me. What surprised me in the adverse childhood experiences or impact of trauma on health and well-being research. And I should mention here, qualify that I was limited to English, publications in this, was that it's so hard for us to do prospective cohort, these huge studies that Scandinavia, Finland can do. And what I saw was a giant affirmation in major prospective cohorts in Finland showing the same findings that we saw in our cross-sectional data in Alaska and for the United States, and similar in Sweden. And these were, 15,000, 20,000 followed, longitudinally for 20, 30 years because they have the capacity to do that kind of research. So they could go deeper with it, and it just lent more understanding to it. But the differences, not so much, across socioeconomic status and so forth, because they would have information like that in terms of jobs and so forth.
So my question is for Linda also. You mentioned schools that are school-based programs. Are there a lot of districts or sites that are accessing this or trying to do this in Alaska?
Yes, and in different ways, in different models, which is great, because that's the thing about having a cookie cutter idea around trauma-informed care, I think is really quite problematic. There's statewide efforts. The state of Alaska is working on an initiative that I understand is going to be piloted in Anchorage and one other region with a particular program out of Washington State that's all over the country. Laura, you might want to be talking about the school-based initiative, resilience initiative work that you're doing, and just working with school districts all over the state in different ways. So very responsive.
I'm trying to get a handle actually right now on what is everything that's happening around the state, because we keep hearing. So Juneau is piloting the Clear Trauma Center model from Washington in 3 of their elementary schools. We're working with the Anchorage School District directly to do training of all, in fact, it'll be on November 10th, all of the elementary school staff in the Anchorage School District will be trained. The Matanuska-Susitna Valley, it has been working with an outside contractor to do trauma-informed schools across their school district. The Chicaloon Tribe School is very trauma-informed, and it looks different in their tribal school than it does in many other schools. Nenana School District is working. So there's a lot of distinct efforts, and then the Alaska Association of School Boards is working with 7 school districts to become trauma-informed and culturally responsive schools. And then there's the State of Alaska Department of Education and Early Childhood Development created a trauma online training for teachers. And they're also they've been leading a program called Alaska School Challenge or Education Challenge. And this is one of their priority areas. And there's an opportunity right now for some policy around it.
And ASDN too, the Alaska Staff Development Network, which is another statewide, has done several series around trauma-informed schools. I know several schools in Fairbanks in February, then at the special education meeting coming up in February as well, in Anchorage, 3-day training for statewide for trauma-sensitive schools, trauma-informed.
And a lot's also happening with after-school programs with the Alaska After School Network.
Thank you. I have a question for Stacy. Stacy, Alaska was one of the 3 hubs. Congratulations on that. I was wondering, will there be any connection to those other hubs or comparison of results?
Yes, that's a great question. That's an exciting component of this, is that this particular kind of grant through the NIH is one that, yes, we will be having quite a bit of oversight from our program officers, but every year we'll be meeting with 3 hubs together. There'll be we meet monthly now, actually, the PIs of the project do to share. And I should say the other 2 hubs, one was awarded to Johns Hopkins University. They'll be focusing the work in the Southwest. It's the Southwest hub. Johns Hopkins have had really outstanding research the last 25 years with the White Mountain Apache in particular, incredible surveillance system there. And then Dr. Spiro Manson and Deidre Buchwald, they have the other, it's an urban American Indian and Alaska Native Base Center, and they actually have a component of their project will be based at South Central Foundation. And they'll be doing like a text messaging intervention, things like that. But yes, and so that will be part of, and when we have our Alaska Collaborative Hub meetings, again, first one in April, everyone. So we talked about having representation from at least one person from the other hubs there, so that we can be sharing.
So I have a couple of questions and miscellaneous comments that maybe would evoke a little discussion among you. So with regard to the CTRC, I'm curious about the length of the grant and also how it will be evaluated. In other words, what does success look like at the end of whether it's a 3-year or 5-year period of time? And presumably somebody is responsible for sort of maintaining over time the right kind of information so that there can actually be a determination that this approach works or that this approach needs to be altered. So that's one question. Laura, you talked about a collective impact approach and the fact that you had already set up sort of a statewide network of the entities that are really focused on this question of resilience and the question of trauma and community resources. But I heard the Collaborative Hub for Research on Resilience saying you're going to set up a network. So I have to sort of say, if the network's already there, and if we're interested in collective impact and building on what already exists, maybe you guys should talk. And Linda, when you talked about vicarious or secondary trauma, and I thought about one of the questions that Laura had posed at the beginning, which is, we know some of the villages are incredibly happy, healthy, successful, very rare incidents of child sexual abuse or criminal behavior, etc. And we know others are really troubled. So I have to wonder, another way of looking at that research question is, in those really troubled villages, which can be identified by the Alaska State Troopers, by ANTHC and the hospitals, etc., they know which villages have consistent problems in the suicide arena and in others. Is there any research that looks at this question of secondary trauma and the vicarious trauma that collectively creates these sort of communities that are sort of sick versus communities that are really healthy? So anyway, those are mine. I go first.
Do you guys want to remember your questions? I have a quick metric to remember mine. So my question was related to the length of the program and metrics of success. The length of the center grant is 5 years. The NIH hasn't made up their mind whether they're going to renew it. It'll be a renewable grant for another 5 years. I suspect it will be. This is much along the same lines of their Center of Biomedical Research Excellence grant, which we had for 15 years. After about 3 years, they said, we'll have another 5-year cycle. After about 8 years, they said, we'll have another 5-year cycle. And then we all begged for another 5-year cycle, and they said no. So it's 5 years. The length of the period of funding for each investigator that you saw is 1 year. They can compete for renewal, and we highly encourage them to do so because you don't develop partnerships really quickly in rural communities. The metrics of success from the NIH perspective, success at getting an independent investigator initiated grant doesn't have to be from the NIH. It could be from NSF or USDA or the Robert Wood Johnson Foundation, you name it. And publishing papers. And it's unfortunate that those are just the two metrics, but that's what the reviewers of the center grant will look at. How many of your investigators got a grant on their own or published from the funding that you gave them? We have a more internal approach, and that's to look at successful engagement of communities, partnership building, capacity building, things of that nature, engagement and hiring of local people in the rural communities, things like that. But honestly, that doesn't count at the NIH in terms of getting the center grant funded. It's publications and grants.
Want to tag team this?
Yeah.
You want to go first? Go ahead.
Well, I'm glad we met today and are able to talk now.
I'll just say about Alaska Resilience Initiative, I wouldn't say we've built it, I'd say we're constantly building it, because every day I learn about new connections that we need to make. And we're not trying to force everyone under a certain umbrella, but rather let people know that we exist and that we're a hub for connecting people. So our website is meant to serve as a place where people can submit events and tools and resources and information about the regional coalitions. Other people can go to it. You know, individually I connect people. People can become involved from around the state in order to leverage our power together to create kind of statewide changes and tools. But I'm constantly learning about new things that are happening, and whenever possible, I love to be able to just set things in motion or support them in motion rather than control them. So we don't want everything to have to come through us as the Alaska Resilience Initiative, but rather play whatever role we're needed to play. And so I'm glad, I suppose we'll have to figure out what our relationship will be. But I'm always glad to know that there are other coalitions, and I just don't want us to end up doing the same work. As long as we're doing supportive work, that we can refer to people to each other.
Yeah, I think it's an excellent point, and this was really fortuitous. So great planning. But again, as we're sharing the hub up, I just want to say that often, there are several different statewide initiatives to create these networks. There are also, it was acknowledged, regional initiatives and networks and groups that are meeting, often though they are focused on particular issues, kind of like what Bert had said, with a certain kind of, okay, we are looking at, trauma-informed care, or, we're focusing on suicide prevention, or, and so like for the anchor, we're, the aim is to create a research and data driven type collaboration. So we're sharing data, and but we, just like Laura, and that's beautifully stated, that we're not aiming with the hub to force everyone to go through UAF, because we're particularly sensitive to that, because we want this hub to eventually move where we feel it would need to move into tribal organizational leadership in the state. And so we're being, really mindful and spending some time, just like Laura said, trying to see how we can potentially just support and make use of the networks that are already established. But potentially we could grow or take on that research focus. So, utilize that network, but, we'll have a meeting that's just particularly focused on data-driven strategies, or how to collect or data on some of these just amazing efforts that are happening in some communities, but aren't really getting counted or seen, because you're required to use particular types of strategies that Bert pointed out are really difficult to get funded or to be acknowledged, because they don't meet certain Western standards for science and research. But it's changing that paradigm, and so I hope we'll have a better report for you in a year or so about how exactly we're working together with all of our partners. So thank you.
Any other questions? Mary?
I guess this is more for Bert. It's not something that I necessarily stumbled upon, but it sort of was brought to my attention in a big way. My campus had applied for a grant to sort of beef up our student services. And one track was to sort of do what's intrusive advising. And one recommendation was to do intrusive advising with a group of students, and then another group of students, you just let them sort of flounder, and if they ask for more help, they get more help. If they don't, and then you sort of see that just sounded kind of awful to me. And so I looked through some field notes from when I, as a grad student, did research, and I talked to some members of the campus advisory committee, and sort of confirmed that this notion of a control group when you're doing research or providing services is, for UBICs at least, it's sort of morally repugnant, culturally repugnant. And I know some of the projects, just when they're titled, probably have control groups or want to look at control groups. for treatment or drugs or whatever. Any response to that?
You're correct. It's not respectful to UPIC people. That's mainly the group that I work with, and we've had lots of discussions about that. Jordan Avey, one of our pilot project recipients, addressed that exact question. How do you conduct a randomized controlled trial in a way that it would be acceptable to the NIH, but also acceptable to an Alaska Native community? And there are certain approaches that you can take. One is delayed onset. Some people use a design called a step wedge design. So basically you start one community or one group, and then a little while later you start another group, and a little while later you start another group. Some people have done away with the control group altogether. We did that in the middle of a project. We have a lower respiratory tract infection grant. Basically, how does PM 2.5 from wood stoves affect lower respiratory tract infections in kids? So we had 3 groups. Control group, do nothing, put in a filtration unit that has no filter in it, a group where you put a filter in it, and a group where you give education. Well, as you might expect, the kids in about 2 days tore apart the filtration unit, and the father tried to put it back together, and wait a minute, this has no filtration unit in it. And he was pretty upset about that. And so we went to the NIH and said, we can't have a control group. It's not culturally respectful to the participants. And they said, that's fine, get rid of it. So that's one little scenario, but I think the NIH is becoming more and more responsive to that. Stacy might want to say more about that. She's had a lot of NIH funding, and I think we just need to keep talking to the NIH, and her U grant is going to be a great opportunity. I joke about U grants. That's where the NIH tells you what you can and cannot do. But I bet Stacy will have a word about that as well.
I think you covered. I think you that. Yeah.
Great. Any other questions? Great.
I don't have a question, but I just want to say thank you. This each of your presentations is just so good to learn about and what all you're doing. So, like was already said, I'm looking forward to the next presentation. How we're all working together holistically with what you're doing. I just appreciate it very much. Thank you.
Right, and thank you to all of our panelists. That was a really great discussion. So I have a quick surprise. We do have lunch scheduled